Hi, Tarang and Ashok. Good evening.
Good evening, sir.
Good evening, sir. So, good evening and welcome everybody to this second episode of Wednesday Musing on the topic of CME for orthopedic surgeons or CMEs in general for medical professions. So, we have with us Professor Dr. Borate, sir. Welcome, sir.
Welcome. Good evening.
And we have with us Dr. Tarang Khairnar, who is our moderator today.
Hello,
So,
welcome. Thank you, sir.
so for further proceedings, I'll hand it over to Tarang. Over to you, Tarang.
Thank you very much and welcome everyone. And in our last Wednesday musing, we spoke about the continuous medical education. And this is the second part in continuation with our last musings. So in our last meet, we spoke about the importance of the CMEs, the need for the CMEs, and the different forms in which we can offer continuous medical education to an orthopedician, or for that matter, any physician. And we also spoke on how they evolved from being a face-to-face conferences and into the webinars. We also spoke on that, the pros and cons of webinars. And we also spoke about the allotment of point systems. And we ended up on a very, in fact, Ashok Shamsar had to put an informal disclaimer that we are not here to dig up on the bigger institutes or the governing bodies, but it is just for the betterment of the whole system that we seriously think over the point systems, and we seriously think over the point system. Are they really apt to gauge the upgradation of an orthopedic or any physician when a CME is concerned? So, and I would like our viewers to also know that it was not pre-decided that we do a second part on this topic, but then it is the need, and it is definitely it would take a whole session to discuss on how we can upgrade to actually make CMEs comprehensive and have a different gauge system to really keep a check whether the participant is being upgraded. So today we'll be speaking up upon that. And Borate sir, over to you now.
Yeah.
Just a short brief on how we can to start with.
So one thing that I would like to mention is that this whole concept of CMEs and webinars is undergoing a rapid change over the last few years, particularly in the Western countries and even more particularly in the USA, because as the webinars and the in-person CMEs are becoming the need for practicing orthopedic surgeons to accumulate the CME credits for recertification. Just like in India, we have to earn like 6 credit points every year, and we get our license renewed after 5 years. In the US, they have to accumulate points every year for 8 years, and then they become eligible for recertification. Their process is a little more specific to the specialty, and it is directly overseen and supervised by the accreditation body of the specialty, which is the American Board of Orthopedic Surgery. In India, it is still not in the purview of specialties. It is in the purview of the medical council, which generally is licensing authority for both general practitioners as well as specialists. Now, because of the interest in the American board into this process, they have decided and they have made it a gradual policy to to modify the content of CMEs and webinars and make it more applicable and more useful to the practicing orthopedist. And this has been a big change that is happening to a large extent, driven by the needs of CME credits by the practicing community. And although we see it to some extent in our own CMEs and webinars in our orthopedic specialty in India too, they are a little better organized, and they have made certain changes which are supervised directly by the American board. So one thing that they have made a provision for, which is called web-based longitudinal assessment. It's a very interesting concept. What they do is they pick up 100 best articles that are being published in orthopedics in the previous year, and they publish that list as a list of articles which the orthopedic practicing surgeons can use to get their credits. And all the surgeon has to do is to choose 15 of these out of these 100 articles. And he has like 1 year to read them and to digest them. But at some time during that period, before the deadline, he has to undertake an online uh, multiple choice question test, which has 30 questions, is roughly about 2 questions per article. And he has to score uh, 24 out of 30. So he has to score pretty good in these online exams. And once he gets that credit, goes on to the next year. If he keeps doing this every year for 8 years, he will automatically get a recertification. Now, what is the idea? The idea is that the surgeon knows that he has to read that article well, and he has to understand the issues that are highlighted, or whatever is the premise of the article and everything. So he ends up being motivated to read those 15 articles which he has chosen extremely well, and that helps him to upgrade and keep current, because those articles usually are the state of the art, or whatever good is happening, or whatever new is premises that have come up, or so on. So you are now making sure that whoever is your practicing surgeon, he has a choice to take articles from his own interest. So if he is a trauma specialist, he can choose all 15 articles from trauma. If he is a spine subspecialist, he can choose all 15 articles from spine. So in that way, he benefits himself much as the process uh, which allows him to acquire this knowledge. So this web-based longitudinal assessment is something that we should consider applying, at least in my opinion, on a voluntary basis through the National Association, if we can interest them in this idea. And once we start doing it, then it will be, since it is already in place somewhere else in the world, and since there is a precedent, it is a good way in which the same idea can be introduced in our renewal of registration. And rather than attending something or anything and getting any credit, those people who are interested in really updating themselves will have a mechanism which will be very good and very beneficial to both the organization and the certifying authority, as well as the surgeons. So this is one interesting idea that I thought we should know about. The other one is, of course, that they are having any number of CMEs, either in person or in the form of webinars, where they are having whatever topics that they choose, and whatever association or body is conducting that CME. So the only thing that now is changing is that they have done three things. One is that they asked their speakers to deliver 3 or 5 practical tips that the orthopedic surgeon could put to immediate use in their practice. And they are saying that the content should not be lectures, but it should be uh, demonstrations of operations. It should be, you know, some hands-on element should be there, and it should be in the form of, like, some techniques which are demonstrated, or there is some discussion, there is some debate, and which involves the audience as well. And there should be enough content of difficult cases. So using all these mechanisms in place of didactic lecture um, is what is evolving more and more now. Yeah.
Yes, so we were speaking about uh, skipping the didactic lectures and having an interactive session.
That's right. The the uh, the importance of this is cannot be overemphasized. That for the practicing orthopedic surgeon, most people are not receptive to a lecture which traces the history and a lot of theoretical aspects of whatever that is being discussed. So they really want to know uh, and get information which they can use in their practice, and which is important to update them in which will help them in their practice. So there are uh, there are any number of such events that are now happening. Now, there is one interesting thing that uh, example that I can quote here is that this organization AO. AO is conducting training programs all over the world for orthopedic surgeons. So they did a change in the way they were conducting their master courses, and they have done a study on how they improved and the outcomes and all that. So they found that they needed to do three things. One is that they started doing serial needs assessment of trainees. So before the course started, they would ask the trainees to fill up a form, finding out what they would like to know about topics that were on the agenda. And then after the program, they would get them to fill a questionnaire to find out whether whatever they expected was delivered or whether they got it. And they kept doing it even before they planned their events. Then they, as we already talked, they switched from didactic lectures to problem-based learning. So problem-based learning is where you teach the same principles, but through actual problems and how those problems were tackled. And the audience also is involved in the process of finding the correct solution to the problem. And naturally, the problems would be also highlighted through cases, like, for example. So, if a particular technique was to be demonstrated, then, and if the importance was to uh, highlight the common errors that are there in that particular thing, which and how to avoid them, for example, then naturally it's a problem. Problem is to minimize errors, and the problem is then discussed in terms of what are the possible errors and why they occur and how they can be minimized. And of course, then some cases will be discussed which had those errors or how those errors were avoided and so on. So they switched their complete agenda and stopped giving didactic lectures and changed it to problem-based learning and case discussions. And the most important part that they found was that they needed to train their faculty, because most of their faculty were senior and pretty accomplished orthopedic experts who knew the topic, who knew how to teach it, but who did not understand or needed to be uh, unlearn whatever they had in terms of how to teach. So they were told, no, you will not do this. And that is what required, that was the most important uh, element of success. If they were able to train the faculty well, and you will also be surprised to know that they found that it took them 5 years when they decided to change from their old format to this new format. They started in year one, but they found that their format was coming up to their own expectations. It took them 5 years to reach there. So this is the problem we have in India uh, with most of the teachers and most of the experts who are participating in these CMEs. They are basically teachers who are used to a certain way of delivering how they teach and how they talk, and that needs to be changed. And to do that, to you need to change the way you're educating people, and you need to find maximum participant engagement, you know. And it takes a long time for even experts who know the subject matter to teach differently, to approach the process of teaching learning differently. And I'm sorry, but I don't think that this is very well understood in the teaching fraternity and in the people who are conducting and organizing these CMEs in India. They understand the basics of what we just talked. They understand the need for what we just talked. But the way they are ending up delivering the change is still leaves a lot of potential for improvement. So this is what I wanted to talk about the in-person CME.
Right. So, and the points which you made are very much, I just observed, realized that all these points are within the limits of we don't what I'm trying to say is we don't need a governing body to mandate and to make these changes. We as an organizing, or we as a or Indian Orthopedic Association, we ourselves can make these changes within the conference itself, rather than going for the conventional ways of the conference. We can make these changes, and it will have a greater impact. For
Yes.
example, the longitudinal assessment program which you mentioned initially, I
Yeah.
don't think any governing senior authority would have a problem if we come up with something like that.
Yes, and it will also create a mechanism for the senior experts in the orthopedics. And it could be like, as I said, if we assume that there are 5 important subspecialties in orthopedics and we have to decide on 100 articles, we could have a body of 5 experts from each subspecialty, and they will have to come up with 20 articles um, every year, or they may continue with the same article if they don't find enough new articles that they wish to recommend. But so that that bouquet of 100 articles would have enough articles from each subspecialty. So the general orthopedic surgeon would have the choice of choosing from all specialties, but the subspecialists, like someone like you, would be more than happy to pick up only 15 articles from pediatric orthopedics. And you would be absolutely delighted to read them well and and give a test on that,
True,
because
true.
it's a win-win
Because
for you.
yes, yes, and here, because you mentioned about my subspecialty, I would like to mention that the IFIX, that is the International Fractures in Children Symposium, we they do conduct journal review every week on Zoom, and we get to choose. Anyone can choose an article which they want to review, and they can present it, and others can freely join and attend the session. So that is a wonderful take. Take.
See, the good part of subspecialties is that they since they have to only focus on their own subspecialty, they have much more interest and motivation in attending events that are hosted and put out by their subspecialty association. So that is a win-win, I suppose. But for the large number of orthopedic surgeons who are still practicing as general orthopedic surgeons, who they may have an interest in one or other subspecialty, but by and large, the large number of orthopedic surgeons, I would say 90%, are practicing general orthopedics. So they would be benefited by this arrangement of a bouquet of 100 good articles. And it's a very good way in which the association could uh, be the leader in bringing about this change, you know. And in America, for example, it is the American Academy of Orthopedic Surgeons which has taken the lead in this. So the 100 articles for the which are put out by the American Board of Orthopedic Surgery are recommended by subcommittees of formed by the double A AAOS to the American board. So it is a collaboration between the American Orthopedic Association and the American board. So I'm sure that this could happen, uh, uh, and we should consider making such a proposal. Uh, and uh, let's see what happens in that respect. And I suppose also that we could have, like, you know, if you are having a number of CMEs, you know, and webinars or whatever, we right now, the medical council is kind of supervising them, and somebody attends on behalf of medical council. For example, if our national association were to take up the job on a voluntary basis of certifying the quality of the seminar, CME or webinar, in terms of what I just said, those three things, that is the pre and post assessment of the trainees, attendees, and the emphasis on problem-based learning, and the quality of the faculty training that is evidenced in the way the contents are delivered. And if they have like a point system or something, then even the people who are organizing such events will become aware of the importance of these things, and they will gradually become better and better in and the faculty will also become better. Now the AO was able to do it because they have a an organizational structure. They have somebody who is administering the whole organization, effectively. May not be so effective in something like the Indian Orthopaedic Association, but we need to start somewhere, and we need to make the change. We need to change our teachers' mindset from becoming, boring and teachers who only know one way to deliver, which is just talk and talk and talk, and uh, from that to a problem-based approach where you become a catalyst and you deliver only and you guide the whole discussion to ensure that the important points are highlighted. So I suppose that is something that we could do.
Right. So when you just mentioned about the non-conventional, the conventional didactic lectures, what is your view on, let's say, a clinical face-off between two parties or two senior faculty members who differ in their views regarding a particular topic, and we have a healthy debate, an official healthy debate, and then we get to know the learning points from each side?
Yeah, sure. This is one of the tools of how we can bring out the pros and cons of the two different ways of managing problem. And um, naturally, the benefits of both sides are uh, brought out in front of the audience, and the audience also gets a chance to participate. And it's a very good mechanism. See, one thing I would like to tell you is that there, I don't know if I should say it here, but there is recently an article in the, I think, British Medical Journal um, by an orthopedic expert, where they have studied, they have reported a long-term meta-analysis, 10 common and popular orthopedic interventions and operations. And they have shown that 6 out of those 10 interventions, the long-term outcome of non-operative treatment and operative treatment was the same. Okay. And this is such a shocking and such a thing that it was reported by the New England Journal also in its column of Journal Watch, this particular article. And I mean, just to give you an example, one of the procedures mentioned there was this slab tear, and shoulder arthroscopic repair of, and versus doing nothing. And that they have shown in a very large and very uh, good evidence that the outcomes do not differ. So this is something that will, of course, this is going to be a big controversy in the months to come, because this is just published a few weeks ago, and it's going to create a lot of um, indignation amongst the subspecialties in orthopedics, because most of the operations therein are related to subspecialties and so on. So,
Right.
so and they're really it's a really interesting paper that has been published in the BMJ recently.
Yes.
But coming back to the what you said, um, the what I wanted to also point out is that all the good journals are also now changing the way they uh, uh, put in their material. Like the focus is still on research papers, but they are now introducing certain things. Like, for example, the Journal of Clinical Orthopaedics and Related Research has now started a section called CORR Insights, which is a 3-question format uh, for the busy surgeon. So they select a topic and they ask an expert to give uh, or a procedure or something, and the what they are supposed to write is where are we now in this particular subject, where do we need to go, and how are we going to get there. So these and this is published under the banner of CORR Insight. So you're looking at insight into, let's say, Decker veins disease, or whatever, any topic they might pick up, and the author or the reviewer or the person who is asked to write review is a very senior person. But instead of writing the history and what had happened and all that, he is only putting it into 3 sections. So it will be short, and for the practicing orthopedic surgeon, it will be a real jewel because it gives him everything that he needs to know, after he reads that. The same similar format they are also using, uh, that you just mentioned, clinical face-off, in the journal itself. So they will have debates where, for example, I'll just give you 2 examples. Uh, Arthroscopic meniscectomy, whether it should be done or not done in patients with early arthritis. So there could be a debate in which somebody says yes, for, and somebody says against, and whatever. And the other topic, for example, is whether acromioplasty should be used for management of patients with rotator. Whether it should be used or should not be used, something like that. And then there is another mechanism which they are now adopting, which is called editor spotlight. So that is like, take 5. So there is a commentary, and a 5-question interview in which the author of the article takes readers behind the article. So the reader it is presumed that he has read that article, and it's a very general topic and a very good article. And he has to answer those 5. He's asked 5 questions about the article, and he has to answer. And those question answers are published as editor spotlight. So these are mechanisms that are going beyond only pure publishing of papers, which will interest the readers who don't have time to read all the papers. But these are sections which they will probably read more. One other thing that is very useful, according to the American Academy of Orthopedic Surgeons, is that they have a committee or a large body which publishes what are known as clinical practice guidelines. Now, they may be separate guidelines for subspecialties as well, which may appear in their annual publication, or they put it out annually, and they every year review and update those guidelines. So, like, if some significant article has come or some evidence has been unearthed that a particular thing which was there in the last guideline need to be take mention of that change. So that's why anybody that needs to know whether he is practicing the correct and the current way in which it is recommended, they have these clinical practice guidelines which are revised and updated every year. And they take into account all the articles and reviews that have been published. And the compilation is a high quality distillation of the essential evidence from the mass of available papers that are there. And you know that Ashok Sham and of us have been involved in making such publications. For example, there was a compendium on surgical site infections, which Dr. Parag Sancheti and was one of the major authors with a large international faculty. And there are like similar things that are published, like preventing venous thrombosis in patients undergoing elective hip and knee surgery. So, topics like this, there are guidelines published, and it is good for surgeons to be familiar with these important practice guidelines and have access to them whenever they need to refer to them. See, one common question that people want to know is what is going to change? What does the future hold for us? Whether
Yeah,
we
so that's
are
what. Yeah, so that's what I was wondering. All even the last 2 points which you mentioned, or the changes which you suggested, they are well within our reach. We don't have to, for example, we don't have to depend on the governing bodies to allow us or to fund us for simulation. Let's say we discussed a lot on the simulation as well in the past. So all these are small minor changes in our curriculum which are within our reach, and we don't need any permissions from the governing bodies. So that reminds me, from simulation, what is the future about, how do we take this ahead?
so so first of all, I think that as we become more knowledgeable, mature, and trained to understand uh, the purpose of CME and the audience, that is the practicing orthopedic surgeon, who is the recipient of the contents. Uh, they will get more and more crystallized into uh, events that will, first of all, not take as much time as they take now, maybe, because they may have mechanisms which will allow the participants uh, to see or participate in a manner which allows them to get the most in the shortest possible time, and they would be more like, now we are mostly demonstrating. For example, if now we are demonstrating operations and we are trying to demonstrate, say, a TKR in a valgus knee, for example. 5 years from now, the topic would be 5 important things to remember while doing a valgus knee TKR, without actually demonstrating the whole operation. There would be, the surgeon will be, as he talks about each point, he will be maybe show a clip of what how it is done on the operating room. So instead of the thing going on for, say, 45 minutes or whatever, the same will be in, say, 3-minute sections of 5 points. So it will get over in 15 minutes. So that is how uh, the things will change, because it will be assumed that people who are listening are already aware of the procedures and they're doing them, and they just want to learn those things that are important. So we you'll see more and more of abbreviation and specialized inputs rather than the longer sessions that we are having now.
We'll be skipping the formalities and coming to the point.
Yes, yes.
Yeah.
And also, simulation, as you said, simulation is going to become more and more popular. And I foresee that, 10 years from now, uh, people will be going to the annual conference. And the annual conference, you have these, stalls where the implants and, mm, various things are demonstrated. So they will be replaced by an arcade, where you will, there will be simulators there. And you, so if there is a company that is selling, say, trauma related implant, so they'll have like 20, booths where you can just sit there and you can decide what operation you want to do, or uh, you know how you want to practice something, and how you scored in uh, doing something, and what did you miss out, or whatever it is. So the orthopedic surgeons will be sitting in the arcades and sort of playing games with uh, simulation, because like in a aircraft training, you sit and you fly the plane, you pick it up and you bring it down. So in the same way, it will give you a choice whether you want to do a valgus knee operation just now and see how it goes.
Yes.
Whether you're get.
When you mentioned about you can play with the simulation,
Yeah.
it just as you were speaking, there is this, I would not like to name the company, but there is this industry of infotainment, that information and entertainment for the kids as well, where
Yes, yes.
at a particular setup they ask the kids to be sell tickets on an air counter, on how on a regular basis it would be. And someone would ask, your kid can be a dentist for another kid, and he can explain how, what procedure I'm doing, and get the consent, get the signed consent, counsel him. So these are the practical learning solutions we are coming up with for the kids as well. And it's high time that we start with the simulation in India, if this is the scenario.
No, it's not about India or anything. See, simulation is a technology that has been around for a long time, but nobody had up till now realized its role in surgery. That's the thing, because like you have simulation for driving a car. You have so many programs, and you can sit and you can even undergo a driving test uh, through a simulation. And if you don't, uh, they have like a series of situations where you're asked to do it, and if you don't do it properly, then you fail the test, and you come back and do it again and practice at home or whatever. So the potential for simulation as a useful technology in teaching and learning surgery and surgical techniques and surgical procedures somehow not wasn't understood or explored. I think mainly because of the small number of potential buyers. So everybody drives a car in the world. I mean, if you look at the number of people who drive cars, it was a need and it was therefore explored, and the technology became cheap also. Whereas if you look at aircraft flying, the technology is there, it has been developed, but it is very expensive. And because the number of users are very few, but it is compulsory for them to use the simulation because that's the only way they can learn. So it is there and it is being used. Now, in surgery, you see, as simulation becomes more effective and more profound and more technologically advanced, it will start becoming mandatory for people who, as a part of their training. And that is the future that I see, because all over the world, this problem is there, Tarang, that
Yes.
a trainee, he cannot operate on a patient because the patient, there's a liability issue. You see, every patient, he, he has a right to get the best treatment. So why would any patient opt to be operated by somebody who is learning to operate? I mean, think of it logically. So very fast, even in the Western world, becoming an issue that trainee surgeons are not independently allowed to conduct operation. It's going to be even more difficult as more and more patients become aware of their rights and their freedom to exercise those rights. So simulation is going to be the way ahead. If you want somebody to become good at something, and so good that the first time he is asked to do it independently, he can do it well. So this transition from a apprentice and a uh, model where a trainee surgeon works as an apprentice with a practicing surgeon or a surgeon who's licensed to operate, and he sees what he's doing and he learns what he's doing and he practices what he's doing, and then he does small parts of what the surgeon is doing, and then one day the surgeon says, okay, I'm going to stand here, you do the operation. So this is known as an apprentice model of teaching learning. Now we are going to reach a point where the entire apprentice training will be uh, supplemented by simulation, and only at a certain level where so it may happen that after you get a license to practice, you may have to do your first 50 or 100 operations where a licensed person is standing by with you to ensure that the patient's interests are not uh, jeopardized because you are still learning technically. So something like that. So this is what I see is going to come now. That even people who are certified to practice will need to have a certain number of, like a pilot, once he, even if he's flying independently, he's licensed to fly, has to fly a certain number of miles with somebody sitting beside him who can take over if required, till he is allowed to fly independently. So simulation is coming in very effectively, and it's only the cost that is holding it from being used more widely, and it is also the lack of uh, inclusion of simulation as a learning tool and making it mandatory. That will take some time, but it will happen. It's going to happen. How quickly it'll happen in our country, I can't hazard a guess, but we are a little much lower than the rest of the world in uh,
Right.
these things.
Right. So, all in all, I think Ashok Sham sir would be excited now to talk because we spoke out so much about his expertise and from
Yeah.
web-based longitudinal assessment to journals being an important part, using journals as a important tool. So, what are you, Ashok Sham sir? What are your thoughts on this?
Sure. Thanks, Taran. Yeah, so I think we have comprehensively covered most of the points. Taran, you wanted to leave, you can leave for the time. I'll take it over.
Yeah.
So we spoke about almost everything comprehensively, starting from CMEs, online events, physical events, and journals and simulations. My point is, all these things are already existing.
Yeah.
So, what makes it so difficult for us to embrace that? And how we can ease that process?
I think that because, one of the problems is that although because we are such a large country, and because education is not a centrally, even higher education, not a centrally administered and controlled as effectively as it is in some other countries. We have a certain amount of variation and a certain amount of difference in the standards, perhaps difference in the quality of delivery of the programs, and that's what makes it more difficult. And as we already discussed, the regulatory authorities are mostly controlled by the government, and the professional associations are, and the experts, so to speak, are only those that are part of the government and the governing bodies that have been regulatory bodies that are uh, mostly staffed by doctors who work for the government. So that kind of restricts the ability of these bodies to be forward-looking and to be more, mm, you know, interested in raising standards, increasing quality, and embracing change, as you say. So we are like, as I told you in the last talk, that the uh, changes in the education that were expected, that are happened in the other countries 20 years ago, are now made mandatory for graduate medical MBBS. But that story has started 10 years ago in India, but it's still not reached the point where the regulatory bodies are even considering applying it to postgraduate. So, whereas if you look at the United States, the postgraduate education already has everything in place, and they already have made a curriculum requirement of using 25% of PBL, that's problem-based learning, in the delivery of the curriculum. So, and they'll go to 50% and so on. But we are still pretty slow. And the reasons are what I just said. And I don't have any solutions, but I think that our professional bodies have to at least take up something and try to create what I call as prototypes, or lighthouse ideas that uh, once they are implemented, to volunteers. I mean, there's no compulsion on anybody, but if they have a mechanism that certifies or rates um, seminars or CMEs, that itself would be a mechanism that would improve the quality of CME.
No,
Right? So,
we are having the accreditation, but it does not depend on at all on quality of the content.
yes.
It
So,
is,
yeah,
I have no idea
because
what it depends on.
see, this is such a contentious issue in India, because we have this thing that anybody who is senior and who is experienced is by definition better than the person who is having less experience. So if I am a professor, then nobody can question me, nobody can rate me, nobody can decide whether what I have done is good enough. So that is what is the problem. we are unable to look at ourselves critically. Maybe something that is part of our psyche. I don't know. We are not looking at what I'm talking of is peer review. I mean, you may be one of the people being reviewed, even though you may be a reviewer yourself. But if you are you are organizing a CME yourself, somebody else will come and rate your CME, and they may not find it good enough, or they may not give you a good rate. And the fact that the rating depends on a certain set of criteria, which are already defined and which are already known to the organizers, is a sure way of ensuring that at least the purpose of rating is achieved, and more as time goes by.
Right. Yeah, I think ways of imparting knowledge to people who want to gain knowledge, we are developing on it slowly. But at the same time, we should also have a review system of how we are doing it and what improvement we should look at. So I think we should do and have a vision about both these aspects rather than doing one and then thinking about the other.
Yeah, I'd like your opinion on the thing that I mentioned about journals. Like CORR has this insight, uh, and they have this clinical face-off section, and they
Right.
have the editor spotlight section. Uh, do you see them as useful additions to journals where you are also involved, or you're already doing some of these things?
No, we are not doing any of these because I like to read them, but like you said, like you talked about the rating of the CME,
Yeah,
these again become quite subjective,
yeah,
isn't it? So sometimes I like them, sometimes I don't like them, and so after a period of time, I stop reading them. I read the article and make up my own mind rather than looking at the commentaries. It's good to have commentaries. I mean, some people will like it. It's a personal opinion. It is working. That is why CORR is continuing with it. So
yeah. And
that's fine.
I just feel that you know uh, editors of journals are people who are pretty knowledgeable, and these are mechanisms which allow them to utilize that knowledge effectively, because writing editorials should not be the only place where people with expertise and experience should be utilized. Uh, these are areas in which, like editor spotlight, and so many, because people who have been doing this for like 15, 20 years, the amount of insight that they have in the whole process of research and evolution of knowledge needs to be utilized more than just critically evaluating public papers and deciding whether to publish them or not. I mean, all that goes on behind the scenes is important, and it is necessary, but there should be more stuff in journals that is not uh, in the standard format of a original research. Um, and I personally would be happy to see some of these ideas being implemented. I see some of these ideas being used in the uh, Mohit Bhandari's thing that keeps coming to us. Um, so, and it's of course going a little more beyond orthopedics, but I think what CORR is doing and what the AAOS journals are doing is, and I also found the evolution of the master's course by AAO and the candor in which they admitted that it took them 5 years to change the thinking of the same experts who were delivering the courses and to make them metamorphose into a more effective uh, participants in the teaching learning process. So,
Yeah. So on the same point that you made about journal being, uh, so I wrote actually an editorial in way back in 2016. I'll just share it here.
yeah,
Training by publication. Can journals be a mentor?
yeah,
This is exactly what we are talking about, and I have written something. I mean, elaborated on the same idea on how a journal can become a mentor and help in training of students. So, yeah, uh, we have been doing it in some parts and parcel, but not very successfully. But I think yes, journals have good network, they have good readability, and they have a power of the editorial team, so they can really help in mentoring. So yes, they have good potential.
and, and for example, I mean, just since we're talking, like you have YouTube, which has any number of videos that are being put out there all the time by orthopedic surgeons all over the world. But I mean, experts who are like editors and so on, why don't they curate whatever is out there and recommend that these are the few things that we feel are the best amongst what is available to understand and uh, learn about something? Because there is nothing at the moment for the person who is going to want to learn and something, he has no way of knowing what is available. And out of the 100 things that are available on a particular topic, which are the five best things that are there? Because like you you have in the magazines, always a section which tells you what are the good books that you should read. What are the books that have come out, and amongst those that have come out, which are the good ones? So why don't we do it as a public service? I mean, as a service to the orthopedic community. Again, I don't know if it will be popular in terms of how the people who are putting out material will feel about you. But, this is more like what I call a
Just in brief, can you tell me in 2 sentences what you feel this idea will be?
See, the idea is similar to what is known as quality assurance recommendations, where, I mean, suppose you wanted to buy something in the market like art or something, and you wanted to know that uh, this is the type of, this is your budget, and amongst that, what is available and which is the, uh, considering your requirements, whatever they are, what is the best thing? In the same way, people who want to learn orthopedic surgery and want to become familiar about a particular procedure before they do it themselves, or as a way of revising their knowledge and mental memory. They
Understood.
want to, yeah,
No, that is a great idea. We actually worked on it for some time,
yeah,
and so we called it something called as Ortho Papers, and we started doing it on Twitter
yeah,
for a long time. So
yeah,
we would take a paper and kind of review it, bring out, highlight the important points, and talk about it.
Yeah.
So, but the thing is that it takes a long time and it takes a lot of effort to do that. And somebody has to be really, actually doing it. So, in that sense, Ortho Evidence is doing a great job where they are providing us the evidence summary for uh, important papers all across. Yeah,
I mean, the potential for this is enormous. But I also think that in the process of doing this exercise, one would have to set some standards and some guidelines. Like, you want a demonstration of an orthopedic operation, it should have a limited number of minutes. It should not be like, you can't compare something which is 1 hour in duration with something which is 20 minutes.
right,
So you would have to set guidelines about those things, and you would also have to grade it into two types. One is for beginners, that means somebody who just wants to learn and knows nothing or knows very little, and the other where somebody who is already practicing and has done it, and he wants to learn about some special or some specific aspect of it. uh, and the whoever is putting out the material is catering to that audience.
right.
So there would be like two or three different formats, and there would be some standards like time and um, whatever else, editing and quality and all those, and so on. So it's and now, as I was saying, that you will have certain even more specialized things about 5 things about doing a valgus TKR and valgus knee. The video is only showing you those 5 things, and in a abbreviated format, so you don't get into anything else, because you're going to do a valgus knee tomorrow. You just want to make sure that you don't, you know, not remember the important 5 things.
Right.
So the potential for those kind of things also is there.
Absolutely right. So I think we covered a lot of ground today on
Yes, yes,
various aspects and various points in importance of CMEs. It will be very different format and very different face of CMEs in future. Like you said, we are gonna sit with our, say, just virtual goggles
yeah.
in our homes, not only in the stalls of the conferences, but at our homes, and we'll be virtually attending CMEs all over the place. So,
Yeah, but at the conference stalls, maybe if you you might win a prize or something. And
oh, I can win prize online also. So,
yeah, and in the US and all, they'll serve you wine and cheese and all that while you're playing your game.
no, it's not
So
game. I'm talking about complete virtual CMEs using your headsets, Oculus or any other, the gaming headsets that we have, the virtual
yeah,
headsets that we have. Sorry, not the game.
yeah, yeah, yeah.
And we can attend virtual CMEs and conferences as a virtual person sitting at our home
Yes, yes, yes.
in in
That that
in good
I
3D and in good 3D versions.
see the problem, or the reason why these things are not becoming so not happening happening quickly is because there's not much money in it. the the reason why it's the gaming world has all that is because there's all these kids all over the world who want to play, you know. And how many orthopedic surgeons are there? I mean, you should just look at it. I mean, they just don't count as a market for for the industry, for the gaming industry.
Absolutely.
Yeah. And
So
so that's
hopefully,
the
let's see if we can borrow something from gaming industry. Why not? As the technology advances, it becomes cheaper and then it's widely available. So that's what I believe.
see, I think that we have to find the money to invest into the people who are uh, code writers for the gaming, and we need to invest money in paying orthopedic surgeons to provide them with the uh, material which they will base their coding on. So it's a collaboration between the knowledgeable experts in orthopedics and the knowledgeable experts in the computer coding,
Yes.
which is expensive, because it's why would somebody do it, even an orthopedic surgeon, unless he's going to get something for it. And that is where we last time ended up with the idea of think tanks or some mechanism
Yes, absolutely.
where funds are made available to explore ideas and avenues which are needed, but which need funding as well, are not going to happen by wishful thinking.
Right.
Okay.
So thank you very much, sir,
Thank you.
and look
Thank
forward
you.
to next Wednesday.